Proximal bicep tendon rupture and subluxation. Transverse humeral ligament between the lesser and greater tuberosity converts intertuberator groove into a canal which has long head of bicep. This is a hypovascular area. A subscapular tendon tear might sublux this long head of bicep medially out of the groove as well. So subscapularis is an important restraint for the long head of bicep. A patient will come with a Popeye sign positive. Ultrasound dynamic test, MRI, increased T2 signal and displacement out of the bicipital groove. Treatment non-operative leads to 20-degree loss of supination and 10% loss of elbow flexion. It can be managed conservatively with elderly, low demand and chronic ruptures. Can give local anesthesia and steroid injection for TDCs and subluxation for pain control. Bicep tenodesis, acute repair in young patients, remove damaged structures and reattach remaining tendon to the humerus. It can be done by two ways: absorbable interference groove or a keyhole technique. Tenotomy in low demand individuals. Debridement in tenodesis not effective. Debridement if tenodesis is not effective. Distal bicep tendon rupture. The sign is called reverse Popeye sign. The contour migrates proximally. Happens while doing bicep curls. Movement is supination and flexion of the forearm is reduced. Hook test for partial tear or no tear. Examiner will be able to get fingers under tendon near insertion from the lateral side. This is done at abduction of the shoulder. Squeeze test leads to passive supination. This will be negative in it. Mechanism is eccentric overload. 40 to 50% loss of supination, 30% loss of flexion, and 15% grip strength reduced. Indication for repair: young, active, and manual worker, full rupture, and partial rupture not improving. The surgery, when done, it should be within 2 weeks to not to obliterate the tendon tunnel. Ultrasound should be done. The surgical techniques are one incision technique, which is anterior approach to the elbow joint, is the preferred approach. Curve incision 5 cm proximal to the crease along lateral border of the bicep, or a transverse 4 cm distal to the flexion crease. The incision is distal, followed by the medial border of brachioradialis. Internervous plane proximally is between the brachialis and brachioradialis, and distally between pronatorius and brachioradialis. Supinate forearm to expose tuberosity and protect pin. Bone suture anchors, interference screws, or endobutton into the radial tuberosity. 2 incision technique, anterior and posterolateral. In 1 incision technique, pin is at risk. With 2 incision technique, more risk of hypertrophic ossification. Chronic rupture, salvage procedure. You can attach the tendon to the brachialis, or reconstruction with hamstick or palmaris longus, or attempt repair in 9 degree of flexion with gradual stretching. Complication: lateral cutaneous nerve injury with 2 incision technique, pin injury with 1 incision technique, Hypertrophic ossification in two incision technique slash synostosis in two incision technique. Radial nerve injury and pin injury is possible.